Ideally, we would catch patients earlier from a therapy perspective, but there's still, options for patients that are diagnosed at a later stage.
Welcome to iCan, a podcast about ophthalmology through a uniquely Canadian lens with Hadi Saheb and myself, Heather O'Donnell. Season 5 of the iCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado iCan vous est offerte par Bayer. Nous les remercions pour leur soutien. We will be sharing our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers.
Dr. Matthew Benson is a clinician-scientist and assistant professor in the Department of Ophthalmology and Visual Sciences at the University of Alberta in Edmonton, Canada. Dr. Benson completed his medical school, graduate studies, and ophthalmology residency training at the University of Alberta. He then completed subspecialty fellowship training in ocular genetics at the National Eye Institute, National Institutes of Health in Bethesda, Maryland, where he was mentored by world experts in the areas of ocular development and malformations, metabolic diseases, inherited retinal dystrophies, and electrophysiology. His clinical practice includes seeing pediatric and adult patients with inherited eye diseases, and he specializes in adult strabismus surgery. Dr. Benson is also the principal investigator in a translational research laboratory at the University of Alberta. His research group investigates disease mechanisms in inherited retinal and macular disorders by generating retinal pigment epithelium from patient-derived stem cells.
In addition, Dr. Benson is involved in clinical research, and he is the site principal investigator for several clinical trials, natural history studies, and patient registries, including the Foundation Fighting Blindness Clinical Consortium and the Fighting Blindness Canada Patient Registry. He works with an incredible group of staff, technicians, and trainees at the University of Alberta who share the goal of developing treatments for patients with vision loss.
Dr. Benson, welcome to iCan. Let's jump into the podcast.
Thank you for having me on your podcast.
Okay, so to get started, first of all, this is very cool, all of this work that you do. We're going to eventually get to chat a little bit more about, and I want to talk about, understanding inherited retinal diseases. But first, can we talk a little bit about where you're spending your time? Because you've got all of this, like how much of your clinical practice are you doing in one place or the other place? Give us a sense of what life is like and where your focus is in your clinical practice.
Oh, for sure. No, thank you so much for asking. I do kind of wear several hats, and I split my time about 50-50 between research and clinical activities. And so usually 2 days a week, I'm in the clinic. Typically Mondays, I'm seeing patients with inherited eye diseases. And then on Tuesdays is when I have a kind of combined comprehensive and strabismus practice. And then I'm usually operating about once every 2 weeks, and I perform surgeries on adult patients with strabismus. And then the rest of the time is dedicated to research, except for the odd day or two a month where I'm seeing on-call patients as well. I have a research lab at university, and then I work with a whole range of staff on that side of the world.
Okay, so this sounds you're a busy guy. In your clinical practice, is your referral base kind of general ophthalmology, or is it predominantly, are you getting referrals in from retina specialists that are like, I don't know, it's always Stargardt's, so, and now it seems like it might not be. So what could it be? Or are these coming from optometry or genetics, for example? Like where's the patient population? How are they finding your level of expertise?
Yeah, so I kind of get referrals actually from all of those different individuals. Probably the bulk of them would be from retina specialists. And most often, at least in Edmonton, I'm kind of following, the footsteps. Difficult to kind of completely reach the level of Dr. Ian McDonald, but he's established such a strong presence in Edmonton that he's been a significant mentor for me for years and continues to be. And so I think a lot of the retina specialists here are very familiar with inherited retinal diseases. And so they don't usually call everything Stargardt disease, and they're usually fairly accurate about the clinical diagnoses. They mainly refer to me for the genetic testing, actually. And so it's really key. I'm really keen to see how everyone is so aware of the moving towards that as a standard of care is allowing patients to have access to genetic testing and promoting that. And so that is something that's been a plus in Edmonton.
Okay, this is great. I look forward to getting into more about promoting access, and because we definitely do want to lean into advocacy today. Because some of our podcast audience is ophthalmologists and some of it's not necessarily ophthalmologists, can you take a step back and give our audience a little bit of an overview of inherited retinal disease, inherited retinal degeneration, and how it tends to impact patients' quality of vision and quality of life?
Yeah, certainly. So the inherited retinal degenerations are a group of retinal disorders that stem from a genetic basis. They differ from something like age-related macular degeneration, or AMD, which is what we call polygenic or multifactorial, essentially a complex disorder that involves genetic and environmental factors. So it's not that you have changes in one gene that guarantee the development of AMD. But the inherited retinal dystrophies are what we call monogenic. And so there's several hundred different genes that together individually cause an inherited retinal disease. And so if a patient either inherits or develops changes in a particular gene, that's what ultimately leads to the development of this retinal condition. The inherited retinal diseases can be broken down into disorders that are relatively static or stationary. They still cause problems for patients with their vision, but they don't necessarily progress. But I'd say the majority of them, unfortunately, are progressive, and we don't have very good therapies for the vast majority of those progressive diseases. And so those ones, of course, have major impacts on patients' vision, and the progressive element makes them that much more significant. The inherited retinal diseases in general can affect kind of all parts of the retina, primarily the outer retina. So the photoreceptors, the light-sensitive structures, the rods and cones, and the supporting cells called the retinal pigment epithelium. But other elements of the retina can be affected too, like the inner layers of the retina. In terms of how they can affect the patient's vision, it depends on where along that spectrum of severity a patient falls. So some patients are asymptomatic. They may have only been identified from other family members who were found to have an inherited retinal condition, and they are recommended to be tested themselves. But other patients can have problems with nighttime vision, with peripheral vision, if it's specifically the rods that are affected. If it's more the cones that are affected, patients can have difficulties with their central vision, their color vision. They can be light sensitive as well. And so these are sort of like the textbook kind of rod-based and cone-based problems that patients can encounter. And then kind of more on a functional level, things that patients that encounter in the clinic that describe in a real world problems that they encounter day to day could be difficulties with, say, nighttime driving or driving in low-level lighting. Sometimes patients with light sensitivity require sunglasses whenever they're outdoors. They may require magnification if they're having difficulties with fine print. And then it can extend to difficulties even maintaining a driver's license. And so I sometimes have discussions with patients about, that they unfortunately don't meet the standards for driving, and that can be, a big factor, and can affect someone's independence quite significantly. And so that's a significant burden that patients with inherited retinal diseases can face. And then it can reach to the point where it potentially affects one's ability to continue in their line of work. And then patients often find that, in the end stage conditions, they depend more on others potentially for navigating, or things like mobility canes or guide dogs. And so there's sort of a whole spectrum of how these conditions can affect patients.
Thank you for that fantastic summary. I think one of the things that I think is useful to go back and just check in on is in terms of timing of diagnosis. Right now, when you talk about the spectrum of these various diseases, if they can affect patients at all, these monogenic disorders can come up at different phases of life. What are the implications for, say, for example, people diagnosed in childhood? And right now, does the timing of the diagnosis have an impact on potential therapies and futures? I think we do have questions about the therapies later on in the podcast we're going to talk about, but what about just the diagnosis and capturing earlier diagnosis?
Yeah, certainly. So from a therapy perspective, it is quite relevant. We do have one specific disease-modifying therapy called Luxturna for a condition caused by mutations in the RPE65 gene. And that is a subretinal gene therapy that requires having a robust cells in the retina to accept the virus that's carrying the normal copy of the gene. And so you would want to catch patients ideally earlier on before degeneration sets in. If a patient is diagnosed at a later time point, they may not necessarily be eligible for certain therapies, but there are others that are being developed, like stem cells and other devices that can assist with vision, that they may be more appropriate for patients in more severe stages of disease. So ideally, we would catch patients earlier from a therapy perspective, but there's still options for patients that are diagnosed at a later stage. And then even just, the sooner the patients are aware of the condition, it has implications from, genetic counseling perspective, family planning. There are other factors that are important for patients to be aware of at an earlier time point.
Now, what are the biggest challenges for making that actual diagnosis? And what can we do in the general ophthalmology office or in other primary care practices to try and capture earlier diagnoses for patients? Is it diagnostic equipment? Certainly, we struggle in some centers with access to electrophysiology testing that would help us pin down retinal dystrophic disease. So can you talk a little bit about, what are the challenges and what can we do to improve that early detection?
Yeah, right. It's a really good point about the electrophysiology. So I might just touch on that quickly. And I would say that for a lot of pediatric onset disorders, the retina often looks relatively normal. And so it's difficult to tell exactly if it's even a retinal problem to begin with. And so the full field electroretinogram is very helpful. And unfortunately, it is sometimes difficult to access the equipment, the technicians to do the tests, and then also to have someone interpret the tests. And so that is one of the barriers. And I guess one option to kind of combat that barrier is to potentially refer a patient to a center that offers ERG testing, but that's sometimes easier said than done, and patients sometimes have to travel for quite a ways away. And so that's why there are often these kind of what they call centers of excellence, or these areas across the country where there's more kind of focused expertise, but sometimes means patients unfortunately have to travel, and that is one of the barriers. For kind of making a diagnosis of a retinal dystrophy in general, I think one of the largest barriers is just from an education standpoint on the referring providers and on the patients themselves. I think we're making leaps and bounds for people within the medical community, within ophthalmology particularly, being aware of up and coming gene therapies and the importance of accessing genetic testing. And so I'm getting lots of referrals, not just from within the city, but from surrounding provinces as well, to help provide a molecular answer for patients. But there still are, based on the prevalence of the inherited retinal dystrophies, we know there's still patients out there who have yet to be identified as having a retinal condition, and potentially have been seen by a healthcare provider and were given a diagnosis of, say, retinitis pigmentosa, and were maybe told once upon a time there wasn't much that could be done, and that can be demotivating for a patient to potentially continue to see healthcare providers or seek further options. And so I think we're definitely making ground there with healthcare providers being aware that genetic testing is important, but that's still, I think, something that we can work on.
So I'm curious to hear more about kind of the patient and family journey for these patients with inherited retinal diseases. So what have you noticed or learned in your practice about the impact on the patients and their families, whether it's emotionally, socially, or financially?
Yeah, the disorders certainly have major impacts, and partly it has to do with how much it impacts the patient's vision. But even getting back to reaching that diagnosis, they talk about in medical genetics this diagnostic odyssey, which essentially captures the patient journey from when they first develop symptoms to when they receive a molecular diagnosis. And that can sometimes take several years and take multiple specialist visits to reach that point. I think we're kind of becoming more efficient along this process, but it still does take time. And that can, even on its own, can be a significant burden to patients and families because of the time taken to visit different healthcare providers and sometimes travel and financial costs too. And then when it comes to the diagnosis itself, in terms of kind of how the emotional impacts it has on patients, I kind of think back to the stages of acceptance. And I'll sometimes see patients in the clinic who have been referred to me and don't know why they've been referred to me. And they haven't really been told exactly, but maybe because the provider doesn't know exactly what to say. And then you're kind of telling the patient that they have this condition that's progressive and there's no immediate therapy available. And it can obviously be devastating news for patients. And, there's anywhere from kind of disbelief to anger to denial, essentially, and understandably so if you're kind of just being given this news. And then on the other side of the spectrum, I see patients who I'll kind of go into the room anticipating I'm going to be delivering this kind of not such great news and thinking that the patients are going to be very upset. And, I'm sure there was a time when they did have those emotions, but they're often very, very understanding, accepting of the diagnosis, and even empowered that they now have something to hold on to, that we found exactly what the cause is of their condition, and they're now excited to see what the next steps would be in their journey. So it's quite a range, but I think it takes a delicate conversation. You have to read the patient as well and get a sense of. I often will ask the patient what do they understand about their condition, just to have some more background, and that helps guide my conversation with them. I'd say socially, vision loss from inherited retinal diseases is maybe can have similar social implications as to vision loss from other, say, chronic conditions like glaucoma. Some things that patients have described to me is if they're in, a crowded mall or shopping center and they accidentally bump into somebody, the person they bumped into maybe cannot appreciate that the patient has vision loss, and it can cause, a rude remark, or people can get upset in those scenarios, and it often causes a bit of anxiety for patients, and they may tend to avoid those situations. Another example would be in patients with macular dystrophy, for example, where they have a loss of their central vision. They'll often kind of use an eccentric point in the macula, which is called this preferred retinal locus. And that usually means that their eyes are not looking exactly in the eyes of somebody else they're talking to. And so they may be looking at someone's forehead, for example, and that patients have just mentioned to me that creates some kind of anxiety because people kind of give them a funny look, or it impacts how they communicate with others. And so socially, there can be big impacts. Financially, we touched on this, maybe a few of these elements a little bit earlier, but if it impacts a patient's ability to drive, or it impacts a patient's ability to work, they can have major consequences on an ability for a patient to generate income for themselves. And sometimes patients end up on disability as well. It all depends on the degree of severity of vision loss, how much peripheral and central vision changes the patient's encountering, but certainly there can be significant financial impacts as well.
And how about the financial implications of current treatment options? How often is that coming up as something that's really affecting patients with inherited retinal diseases right now?
Yes, it's a good question. At the moment, we do have, I think across Canada, but certainly in Alberta, I'm almost certain it's across Canada, but coverage for the Luxturn or RPE65 based therapy. It is very expensive, and so if the provinces weren't able to fund this for patients, it'd be cost prohibitive for the vast majority of patients. It's several $100,000 per eye, but fortunately for the moment, this is covered. But it's hard to know, as more therapies become available and developed for patients, whether all patients will still have access to therapies that are specific for them. And this is one of the concerns and considerations in therapy development for rare diseases. And there's been a bit of a pivot to not only focusing on patient-specific and gene-specific therapies, but also therapies that don't necessarily require patients having specific changes in one particular gene. So that might broaden the therapy to more patients and hopefully provide a more cost-effective approach to treating these conditions.
You mentioning just some of the financial burden reminds me of one of the tips that one of my inherited retinal disease patients gave me that stuck with me about forms. And because the financial burden is really significant, these patients actually really struggle sometimes with just having their providers be available to them to complete the necessary disability related and insurance related forms that they need done. And I would just put a plug in. I don't know if you've had this experience as well, is that the patients might have their diagnosis. They might know that there aren't any treatments, but the thing they're actually really struggling with is getting the provider who actually understands a bit about their condition to just help them out with the paperwork and not for many hundreds of dollars in fees associated with it. So I think for a lot of these patients, one of the things maybe we could do a bit better, I don't know what your thoughts are, but we could help them a lot with the simple things like those forms.
Exactly. I'm so glad you brought that up because it's something I encounter all of the time too. And like as providers, we're obviously very busy, but the patients need us to fill out these forms for them. And they're already a vulnerable population, and you can't charge exorbitant fees for completing these forms too. And I know I don't always fill out the forms as quickly as I would like to, but I do make an effort to do this for patients because it's ultimately what's kind of standing in between them and accessing more resources.
Totally. And I think we shouldn't be, as the general ophthalmologist, the people referring in to a subspecialist like yourself, kicking the can for the forms down the road. It's not fair to the people whose time we need for that specialty diagnosis. Once you give it to us, we should be able to manage the forms for you. So I think that's something where we can maybe do a little bit better.
Yeah, definitely. No, I do think so too. I think it could certainly be a shared responsibility.
That's a gracious way to say that, Matt. I'm sure you're often in a situation where that can is kicked in your direction. That you said that graciously. I'd like to hear more about what you feel are the current critical barriers to raising this important awareness about rare diseases like inherited retinal diseases among both the medical communities and also the general public.
Yeah, I think one of the issues stems back to education and having healthcare providers aware of the existence of inherited retinal diseases and kind of rare ocular genetic disorders in general. I think back to kind of during residency, and fortunately, I had an opportunity to work with Dr. Ian McDonald, but I know not all residency programs necessarily have a built-in inherited retinal disease program. I think they're becoming certainly more of them, which is great. And so if someone wasn't necessarily familiar with these conditions kind of during training, I can imagine it would be difficult to know the signs and symptoms and be able to identify patients with them too. And so that's part of what the difficulties are in kind of reaching the diagnosis is potentially on an education level. And then from kind of a patient perspective, I think patients in general, like there's quite a few patient advocacy groups for rare diseases, a lot for inherited retinal diseases too, and some of them are more gene specific. I think patients are becoming more aware of not only the need for genetic testing, but specific diagnoses and the importance of seeking out a specific diagnosis. But I think it still comes back to the provider, and they're usually the ones that have provided the diagnosis for the patient. And so I think in terms of advocacy for kind of expediting expediting receiving a diagnosis we can do some more work on the provider side, and some ways that potentially individuals can kind of become more aware of inherited retinal disease in general could be through podcasts like this one. There are also quite a few seminars that are virtual throughout the U.S. where one is from KCI Institute in Portland, where they have monthly case rounds for rare inherited diseases that are rare inherited eye diseases. And you can tune in and kind of learn a little bit more about them that way. We're also kind of keen on developing something locally in Canada as well. So that's something that's one of my goals, and that can potentially help increase awareness of these conditions within ophthalmologists and eye care providers. And then finally, we're kind of in the early stages of hopefully creating a bit of a subspecialty day for a future COS meeting, where we can potentially have some lectures on different types of inherited retinal diseases and ocular genetic diseases kind of as a whole, and maybe bring together a group of individuals who are kind of interested in learning more about these conditions. And so I think if we focus a bit more on the education aspect, we'll be able to make a bit more ground.
ICAN wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
ICAN veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
My name is Carissa McAllister, and I listen to ICAN podcasts.
going to change gears a little bit, and I'd like to ask you some questions, if I can, about genetic testing. And I'll try not to I won't use like the sort of commercial names because we don't need to pump the tires of any particular company. But let's just say by chance that I had, you know, sent a saliva sample off to some lab because I got some Instagram post that said, hey, you can learn about your genetic information. And I got the information back. I got a macular report that says you don't have the CFH or the ARMS2 gene. And I was all delighted about that. But a family member did, or perhaps one of the reports came back that there was something more concerning on genetic findings. I'd like to ask you a question about not just how do we do these genetic tests, but I've noticed this commercialization as well of genetic testing that I think is going to have big impacts on how our patients come to us, what information they have. So I'm interested in your opinion on that. And I'd also love to understand better, what does it mean when somebody is doing a commercial genetic test versus the sort of testing that you're doing, and whether it's targeted or more global? So can you speak to that a little bit? I'm sure I'm going to have lots of follow-up questions about it, but
Oh, certainly. Yeah, for the commercial genetic tests, it's a good point. They are definitely becoming more prevalent, and quite a few patients are coming with reports and showing me them even in the clinic. For that particular type of testing, you're generally obtaining something called a polygenic risk score. And so you're looking for changes across a number of different genes, and even in regions where they're not necessarily genes, but across the genome essentially, that are often relatively common changes. And so something like age-related macular degeneration is more amenable to testing like that, where you can't necessarily tell a patient that they have this particular condition. It more gives you a general sense of risk, and it's still an estimate. And so that's not necessarily a diagnostic test. It's more so giving you a risk estimate. And different companies will have kind of different levels of accuracy, validity, and basically different comprehensive reports. And so it's not something I necessarily recommend for patients at the time, unless they're interested in their ancestry or something like that for other non-medical reasons. It's not necessarily a bad thing. You have to be aware of who has access to your genetic testing information, and there's other implications like that. But from a diagnostic perspective, the testing that we do in the clinic is a little bit different because we're looking at specific changes in genes that are known to be causing the disorder that the patient's presenting with. So we're not usually doing pre-symptomatic testing. It's not necessarily to tell a patient the risk of developing a disease necessarily. It's more so for a diagnostic purpose.
Okay. And then tell me about whether or not at your center, do you have the genetic, do you have a lab that's actually doing the genetic testing, or is Alberta are you using a third-party provider, and where is that happening? And are those providers sort of, in British Columbia, we have sort of a recommended genetic provider, as I understand it. And I do think it's a bit of a black box. I'll admit that in my general ophthalmology practice, I don't yet have if I have a patient that has an abnormal field, abnormal fundus autofluorescence, it's symmetric, it's bilateral, I'm concerned that there's an inherited retinal disease, I'm still sending that patient away to get the genetic testing that needs to be done. And I'm very curious about the infrastructure behind the providers that is providing the answers here. And is there a way that we can get that to our patients faster? Like, look, if the province isn't covering certain genetic tests and there's a company that can, should we be having the kits in our office to get the information sooner?
Yeah, these are all excellent, very timely questions, and things that kind of we think about on a regular basis. In terms of how we do our diagnostic testing for patients, is we also outsource to a third party. The reason for that is that although I can do kind of basic Sanger sequencing in my lab, it has to be to a level that's clinically approved. And so that's why we use a third party. And there's several different companies. We won't maybe speak to them in the podcast, but various ones offer different sorts of panels of genes. They're all quite comparable though. But that's generally how we go about doing testing for patients in the clinic. And so it often involves kind of a buccal swab. We take kind of a sample inside the cheek, send it off to the lab, and the results come back in a couple of months. In terms of what we can do in my lab, it gets a little bit into the weeds, but sometimes with the genetic testing, the report comes back with an uncertain result. And so whenever we do genetic testing, it's not always a kind of a yes or no answer. And sometimes you're left with a change in a gene that hasn't been shown before in any patients. And so you don't actually know if that's causing a problem or not, but you suspect it might be. And then there's additional things you can do to increase your confidence or certainty that maybe be causing a problem. And that just depends on your access to, say, a research lab. And so in my lab, we can, in some of these cases, if we get a sense we can increase or decrease our certainty about a variant, we can actually do some lab-based tests to see if, that the gene that the protein that's encoded from the gene is abnormal or not folded properly or not present. There's other things we can do in the lab that I've done in certain cases to try to increase the certainty or clarity of the genetic test result. In terms of accessing genetic testing in general, like, does it have to be someone with medical genetics training? Does it have to be an ophthalmologist with inherited retinal disease practice or focus? It actually doesn't have to be. And I would say that anyone that's interested in learning more about genetics in general can definitely do so. And I don't think that the province has put a limitation on who can order the genetic testing, apart from the fact it has to be an MD, so a medical doctor who orders the testing. The problem, though, arises in there's a few things that we generally as a field kind of would hope are in place as part of this process. And one of them is the genetic counseling aspect. And so the person that would be ordering the testing would need to provide genetic counseling before and after the testing with the patient. Some people feel more comfortable than others doing that. We're very fortunate that we have a genetic counselor that's specifically dedicated to our ocular genetics patients in Edmonton who does this work. And it's a very important service that she provides. And so I don't think I'd be able to easily do that otherwise, because it takes a lot of time. And then the other aspect is the interpretation of the results. And so that's where it can become a little bit nuanced. And just out of experience and kind of going through a genetics fellowship, is I didn't really appreciate some of the intricacies in interpreting the genetic test results until I kind of spent some more time in that area. But certainly for those that were interested in learning more about this, you could potentially order the testing and maybe liaise with someone to help interpret the results as well. And I think realistically, because there's only so many individuals that are keen on specializing in inherited retinal diseases, there's going to be far more patients out there that we're going to need to get testing done on. And I think it's going to be outsourced more to people potentially like pediatric ophthalmology, retina specialists, and maybe as our ability to annotate variants and know whether a change is causing a problem or not improve over time, it'll become less of this nuanced interpretation area that we're finding ourselves in right now.
Okay. Well, that's it's also an interesting look to the future to think about how networks might be created where we can get information to perhaps the people that can help us interpret it. And I suspect as well in the virtual world, and we can maybe even connect with genetic counselors in a way that we're not currently conceiving of. So it's an exciting thing to potentially look forward to. What about the ethics of the genetic testing? I mean, obviously, I get the impression when you speak about the type of companies that are being used for the tests, the presence of great genetic counselors engaged in sharing of information, that there are major stumbles that can occur. But even when these technologies were emerging, there was a lot of talk about well, what if we gather too much information? Or what if there's information that people don't want to know? Or what if insurance companies get a hold of information about patients who are presently asymptomatic? Can you speak to that a little bit? Are those sort of concerns that are bygones now, or are they still real issues?
No, yeah, they're very relevant. And I very much rely on my genetic counselor to help with some of these discussions, because some patients, are not as concerned about that, but there are definitely lots of patients who are concerned about these things. And speaking to a few of them, in Canada, we have something called the Genetic Non-Discrimination Act. So what that is it basically makes it illegal for a third party, such as an insurance company or an employer, to request or ask about your genetic testing results. So in Canada, at least, patients are protected in that sense. But there's also concerns about when we're basically delivering a patient sample that contains DNA to a third party, like how long is that DNA stored for? Who else has access to that DNA? Are there patient identifiers associated with it? Like, of course, there would need to be, and then how are those anonymized? These are all factors that are company specific, but our genetic counselor does help patients navigate through some of these questions because they are very important. And sometimes, patients are still concerned that, their genetic information won't be as private as they would like. And if they had that feeling, they may not elect to proceed with genetic testing. In my experience, probably around, 95% of patients do end up still going ahead with genetic testing, but these are real concerns. A couple of other things that come up quite frequently. One of them is something called secondary findings. It depends on the kind of genetic testing that we are ordering. For the most part, we're doing panel-based testing, which means we're checking for an array of genes that are associated broadly with a phenotype like an inherited retinal disease. But sometimes we do larger scale testing, something called exome sequencing, where we check all of the protein coding genes. This is usually where there's a little bit less diagnostic certainty, other extraocular features, or just some centers have access to exome sequencing, which is fantastic as a first line kind of diagnostic modality. But as part of this, you might find changes in genes that are going to tell you whether you're at risk of particular cancer or heart disease. And the American College of Medical Genetics and Genomics has a list of, I think it's 81 genes now that they call medically actionable, so that if you were to find a change in one of those genes, it would either change how you're followed, screened, or potentially even managed at that moment. And so if we were going to do an exome sequence, we would actually ask the patients if they want to know about these secondary findings. And so then they would be aware at that time. Sometimes patients say no, they don't want to know that. Sometimes they say yes, but it's an important conversation for us to have with the patients. And then with the more common testing we do that's panel-based, we don't really check for those particular genes. But I will say, though, on the panel are less than a handful of genes that have potentially life-shortening implications. And there are these sort of horror stories where patients weren't told that this was a possibility. And then, unfortunately, that result comes back. And then, it's usually in a pediatric patient. The parents are saying, if they knew that, they probably wouldn't have done the testing. And that's obviously worst case scenario. Unfortunately, this doesn't happen often, but it's just another thing to be mindful of is what genes and what conditions are you testing for so that the patients are fully informed.
I wanted to revisit one of the things you were talking about earlier in our conversation today, and that was some of the treatments that are currently available. So can you tell us a little bit more about, what are the current treatments that are available for inherited retinal diseases, and also touch on some of the promising advancements or things that are on the horizon in the coming years?
Oh, certainly. I think what everyone's excited about is kind of the genetic therapies, but even kind of backing up a little bit for things that can be done like, low vision referrals, cataracts, optimizing refraction, treating amblyopia, kind of the usual bread and butter of kind of comprehensive and pediatric ophthalmology. We still definitely want to optimize a patient with inherited retinal disease, their vision, because for a lot of them, there's not necessarily disease modifying therapy. So we certainly start there. Sometimes patients have kind of non-leaking cystoid macular edema that would be amenable to topical carbonic anhydrase inhibitors. So these are some of the considerations we have. And then certain inherited retinal diseases can be associated with other retinal complications that might require intravitreal anti-VEGF injections. So there are potentially certain treatable elements to these conditions that can arise. But in terms of the genetic therapies, there is the one that's Health Canada approved in 2020. It's called Luxturna, and it's a treatment for a very specific form of inherited retinal disease caused by two changes in a gene called RPE65. It generally causes something called Leber congenital amaurosis, and so children are born with very poor vision, have night vision difficulties, and often nystagmus. But some patients can have kind of more of a different sort of presentation, which is more of like retinitis pigmentosa phenotype, where they have kind of peripheral vision loss and nighttime vision problems, and not necessarily the early onset LCA presentation. But by and large, patients with this specific condition present at quite an early age. And so because there's access now to this therapy, this is one of the big reasons why we're pushing for genetic testing, but there are many other reasons for genetic testing apart from that. But just kind of getting back to those secondary findings, the RPE65 gene is now actually included is one of those 81 genes because there's now a disease-modifying therapy available. And there's at least a handful of centers in Canada that can administer this treatment. So it's very exciting, and it just it just shows that all of these research advances that have gone into developing it, have resulted in a meaningful difference in a treatment that's available. And with individuals within the field that are looking to develop more therapies are using the success and learning from how that process occurred for Luxturna to try to develop other therapies for patients. And so that's the one that's approved. And then in terms of what's in development, there are treatments that would depend on specific mutations, or we call variants within genes. Some of those are what are called antisense oligonucleotide therapies or gene replacement therapies. Bit of semantics, but essentially different treatments to specifically modify or block the negative effects of a particular change in a patient's gene. Some of these are delivered intravitreally. Some of them would require vitrectomy and delivered subretinally. And then we're looking at developing, or as a field, developing therapies that are what we call gene agnostic and don't necessarily depend on knowing exactly, while it's still good to have the genetic testing, but don't necessarily depend on that particular gene being the one that's implicated. And those therapies would also be delivered intravitreally or subretinally. These are currently in clinical trials in early phases. Then there are also other oral medications, many of them antioxidants, looking at slowing down the progression of some of these conditions. So they wouldn't necessarily be expected to boost the level of vision that a patient has, but over the long period of time, kind of slow down the progression. And then I think we mentioned earlier about stem cell therapies. These are in an earlier stage of development, I would say, but they're not only being developed for inherited retinal diseases, but also conditions like macular degeneration with geographic atrophy. And the idea is that you're giving back layers of the retina that are missing. And that's still in the earlier stages of development. They're mainly, my understanding is seeing if it's safe to implant these stem cells into the retina, making sure that they're not causing other issues. And then there's also different device developments as well. We did have access to the Argus 2 for some time, but my understanding is that the company is no longer manufacturing the unit, but there's different epiretinal and subretinal implants that have been tried in the past to sort of bypass the damaged retina to provide patients with very poor vision with some degree of light perception. And then one sort of interesting approach is something called optogenetics. The idea there is that you're making layers of the retina that are not normally light sensitive, like the retinal ganglion cells, light sensitive. Usually involves delivering an intravitreal kind of cargo that contains a protein that is light sensitive. And this would be expected to potentially give patients with very poor vision, like some light perception as well. And so that potentially would be sort of at a later stage, more advanced stage of degeneration. And something like a gene replacement therapy might be something considered at an earlier stage if there's still viable retinal cells.
Sounds like there's a lot on the horizon. That's really exciting. In terms of clinical trials, is there a resource out there that you would recommend to patients that would be in a language that they could understand about what clinical trials they might be candidates for and what they should do to try and access those clinical trials? Because my guess is those clinical trials can be very useful for these patients in the short term, and even more so for other patients like them in the medium to long term. So what can patients do that are interested in participating in clinical trials?
Yeah, it's a good question, and patients ask me this quite frequently as well. There are two resources that I generally recommend to patients. One is a little bit less user-friendly, I would say, but it's called clinicaltrials.gov. It's an American-based website, but it includes clinical trials that are international, that kind of from across the globe. It's not necessarily written in a language, though, that's friendly to the understanding of probably many patients. Sometimes even myself, like doing clinical trials myself, I have difficulty sometimes, knowing exactly what the trial is all about. And not all of the trials that are listed on the website too are I would say like legitimate or have been vetted, I suppose is the word. So you can't always be sure that the trial you're seeing on clinicaltrials.gov is something that would necessarily be a good idea to pursue. And so it's still important to have the conversation with your healthcare provider about trials that you find on clinicaltrials.gov that you may be interested in. And then if it looks like it might be something worth pursuing, then on that website, there are the different centers that are participating in the study. very likely the patients may have to travel, but they have the study coordinator's contact information and email address, and that's usually how we put them in touch with the patient. And so it's generally driven by the patient because the patient would be sharing their information with the study site, but we facilitate that process as much as we can and advise the patients. It's a very personal decision whether someone wants to participate in a clinical trial or not, because it's not an approved therapy and things can go wrong. We're all very optimistic that the clinical trial is going to help the patients, but it's more so to help future patients, and it's very much an experiment. And so some patients are more or less risk adverse, and so it's very much a personalized decision and requires kind of input from a number of people as to whether it's a good idea to proceed. And the second resource is on Fighting Blindness Canada's website, and they have a list of kind of eye-specific clinical trials, and not just for inherited retinal diseases, but also my understanding is for glaucoma, for macular degeneration as well, and for certain neuro-ophthalmic conditions. And that's a great resource because it's updated regularly too, and there are links to each particular trial, and not just ones in Canada, but across the world as well. And so I often direct patients to their website too.
Interesting. So beyond clinical trials, what other patient advocacy groups or organizations have you come across that are useful for patients that could support these individuals with inherited retinal disorders or their caregivers?
So there are quite a few. A lot of them are put on by charitable organizations, and some of the kind of seminars or events that I found to be quite helpful, at least kind of in my experience, has been ones that are open to the public and involve both patients and providers kind of meeting together. Fighting Blindness Canada has a series called Viewpoint, and they meet across the country, and they bring together ophthalmologists, eye care providers, genetic counselors, and patients. And it basically is a series of sessions where providers present information to patients, and they have access to asking questions that they don't necessarily get a chance to ask in the clinic. And so things like this are not just from Fighting Blindness Canada, but there's a number of different organizations, depending upon what the specific disease is or the focus is, to provide these patient-driven sessions. And I find that those are quite helpful, and I enjoy participating in them myself too, and find them to be quite meaningful. On top of that, there are other kind of patient resources from different organizations, such as the COS has kind of a patient resource section on their website. There are also other specific disease groups. So sometimes it's a Facebook group, sometimes it's a specific charitable organization that's based, potentially in Canada, potentially in the States, that gathers patients that have a particular condition, say like Usher syndrome, for example. And so it's sort of a support group where patients that have either themselves or family members affected with these conditions can get together and have that support from others that have gone through similar experiences. And also a lot of these organizations put on their own events too, which are often scientific meetings, but also available to the public and to individuals that are affected by these conditions. And I've been to one of those meetings before as well, and they're also excellent too, because you get to interact directly with the patients that are affected and hear research advances specifically in that area and that are tailored to kind of the public audience. Yeah, the other thing is this is more of on a personal level, but as a provider in the clinic, because I see a number of different patients with rare inherited diseases. There's sometimes families that will tell me, if there are individuals that have something similar and you think they would benefit from me reaching out to them or me being put in touch with them to kind of share what my experience is, because these are rare conditions, and sometimes patients can feel a bit isolated and alone, and it's helpful to hear from someone else who has something very similar to what they have. And so there are sometimes cases where the patients are feeling comfortable and they're willing, but we connect them and they have discussions. And sometimes they're similar ages, sometimes not. And I think patients have found value in that.
Oh, that's like such a beautiful advocacy kind of moment, and a like an incredible sort of effort to connect and really care for the emotional well-being of the patients. I think that's a really incredible thing to do, actually. The closest I've ever gotten to something like that is feeling like I should run a dry eye support group out in the front, in the waiting area of I think, you know what, if you really chatted with this patient, you would also understand you're not going through this alone. And what you've done is you've taken that to this amazing scale where somebody who's really being told they have something that nobody else ever has, is that there are people like them. And I think that's, I think in all social connections, finding your community is one of the most powerful things that drives our wellness. So, I mean, I think in moments that's incredible.
Oh, no, thank you. Yeah, no, I found that the patients find a lot of meaning in that. And so you have to be careful because you don't want, sometimes there's obviously patient confidentiality, but
Yeah,
I found that
totally.
patients are often very, very willing to help that way.
There's a part of the podcast where I like to ask if you could wave a magic wand. So this is sort of like whether you want to call it a call to action or just, think about if you could make a sweeping change and tomorrow there is a different policy or a research agenda that you were able to have come to fruition, or something you could immediately enforce that all clinicians, every time they saw a patient, did this. What magic wand would you wave?
From a clinical perspective, it would be that I'd wave a magic wand and have all of the kind of across the board, all eye care providers aware of the importance of genetic testing and that it's essentially becoming a standard of care. From a research perspective, though, I would wave a magic wand and request that the federal government really dedicate resources to supporting research efforts, both clinically and fundamentally, because that's really what drives these the developments that we see in the clinic and the therapies like for LCA that we have at the moment. And so I know that it's a trying time with the research climate in general, unfortunately, but I think that would be something that definitely would want to continue.
Can the COS do more?
I think one aspect of the COS's involvement that might be helpful is because we're kind of keen to, myself and kind of others that are in the inherited retinal disease space, put together this subspecialty day. And so we, of course, would be working with the COS to do that in one of the future meetings. And I think it would just be nice to gather individuals who are interested in inherited eye diseases, and meet new people and kind of cover some of the common topics and common questions that people encounter. And so I think that would be a good start, is maybe to potentially help facilitate one of these meetings in the near future.
Okay. Well, thank you for that. I think we love to connect back with the COS and make sure that we're doing everything we can to advocate for patients across all different realms of advocacy. So I think that's a great tip. I can't thank you enough I've learned so much through this podcast, and in particular things like this idea of, balancing wanting to lean in and potentially consider offering testing to recognizing that indeed there are some risks and there's a lot of information that you have to have about extra information you might gather when you go in and do those retinal panels. And so I'm so appreciative of all this new knowledge. So you've given us lots to think about. So thank you for that. And as we move away from the academic bit of the podcast, we like to ask you questions a little bit about what you do outside of medicine. So we've learned a lot about this professional persona and incredible wealth of knowledge you have around inherited retinal diseases, but tell us a little bit more about you.
Oh, for sure. One big change in my life is that we welcomed our first child. His name's Wade. He's 2 months old, and my wife and I are thrilled. We haven't been getting as much sleep in these past couple of months, but I'm told that it eventually gets better. But others have told me that for 18 years, it's going to be like this too. So I'm looking forward to all of it. But yeah,
that's so wonderful. Congratulations on baby Wade. That's great.
Thank you. Yeah, he's been a big joy to us. And so he's kind of taken up a lot of my hobbies that I was doing earlier, but I really enjoy playing hockey. I haven't been playing as much recently, but I'm a goalie and I play in a few different men's leagues. And play with friends that I grew up playing hockey with as a child, which is awesome that I can still continue to do that. And then on the side, I enjoy watching hockey as well. I live in Edmonton, grew up in Red Deer, which is kind of right in between Edmonton and Calgary. And people often ask me, are you an Oilers fan or a Flames fan? And I tell them I'm actually a Canucks fan. So
oh, there you go.
Yeah, I grew up in Vancouver Island, and that's where I first started playing hockey. And so I've kind of stayed loyal to the Canucks. So that's my little secret living in Edmonton.
You know what? I can totally relate. I'm originally from Regina, Saskatchewan, and even though I've lived in British Columbia most of my life now, I still cheer for the Saskatchewan Roughriders and will never be a BC Lions fan. So I can totally relate to that, like loyalty to your original home team.
Mm-hmm. It just feels wrong to sway from it. So
yeah, I hear you. That's great. And Hattie and I are both parents, and we're both like, oh, that's sleep mystery. It's just such a hard thing. So we wish you all of the best with that as well.
Thanks.
There's no perfect answer. You just gotta get through it.
Mm-hmm.
Matt, that was such an insightful chat. Thank you for sharing everything you did. It's a topic that's so relevant and also so different from kind of bread and butter ophthalmology that I think many of us, it's so easy to lose touch with the details and how best to manage these patients. So thanks for highlighting so many important points that can help us better inform our patients and better take care of them, our patients with IRD. So thanks for all your time and expertise.
Oh, thank you so much for joining the discussion. I had a great time too, and thank you for having me on your podcast.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months. ICAN wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
ICAN veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Season 5 of the ICAN podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
La saison 5 du balado ICAN vous est offerte par Bayer. Nous les remercions pour leur soutien.
Thank you from the Canadian Ophthalmological Society. ICAN is available wherever you listen to your podcasts and, of course, through the COS Practice Resource Center.
ICAN est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
ICAN is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
ICAN est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.